I'm Tom Bagwell, and welcome to Hello Health, a partnership with the Ochsner Health System and Humana to bring Ochsner's Hello Health weekly education and information series to television. Tonight's topic, the prostate, benign prostatic hyperplasia, or BPH, and treating it. Tonight's guest is urologist Julie Wang. First, some background on our guest. Dr. Wang earned her medical degree from the Tulane University School of Medicine in New Orleans. Before that, she's proud to say, she went to Ben Franklin. Her internship in general surgery and her residency in urology was also completed at Tulane, and it is our pleasure to welcome Dr. Julie Wang to Hello Health. Good to have you with us on the program.
Thank you very much, Tom.
Thanks for
Appreciate
being here.
it.
So you're a local girl from here.
That's right.
Just 4 years away, right?
That's right.
Doing your undergraduate work at Vanderbilt University.
That's right.
What made you want to come home?
My parents are still here, and during the time when I went away for college, Katrina hit, and I knew about the large amount of health disparities and the need for coming back. So it was always something on the background of my mind of after I was completed training to stick around and help where I grew up, the area where I'm from.
Good for you. Certainly a need for health professionals, and we're glad you're part of that team and part of the team at Ochsner. Do you remember, Doctor, what it was or who it was that first interested you in medicine, and how about this area of specialty of urology?
I would say from my own family experience, I do have some family members that were dealing with health issues, and that always kind of sparked the need because they always needed some bit of explanation, a translation, because English is not their first language. So I was always often the mediator from that standpoint. As it became further on, I would look up a lot of things on my own and start to find out more on my own research that, medicine is an area of interest to me. And I find that I'm very, conscientious of the need to explain things in a way that patients can grasp. As far as what brought me to urology, I would say that the patients are what brought me to urology. When I did my rotation, often you would encounter a patient who they were dealing with things that they would never tell anybody, let alone a spouse, personal friend, or other family member, things that are so embarrassing or just distressing that they never told anybody else except for a urologist. So to me, that was what really sparked my interest in urology.
So your family is originally from where?
They are originally from Taiwan.
From Taiwan.
Mm-hmm.
Do you find yourself as a translator for others in the hospital system? Hey, we need to go to Dr. Wang. She can help us here.
As far as my Taiwanese is not the best, but I actually speak decent Spanish, so it's a little bit of a curveball there, but I can actually listen to and speak to a little bit of Spanish, especially urologic Spanish.
Mm-hmm. Well, I know your parents are proud, not only of what you're doing, but the fact that you're here with them and here with us in New Orleans. So thank you again
Thanks.
for that. So tonight we're talking about the prostate and BPH. Let's start with the prostate itself. Remind us what it does and where it is in the body.
So the prostate is an organ that no one ever really thinks about until it becomes an issue. It's actually a pelvic organ. It's located very close to the bladder and also close to the rectum. And it may function to help with holding the patient's urine, so a continence mechanism, but it also contributes fluid to the seminal fluid during ejaculation.
And only I have one. You do not, correct?
Males do, and women do not. That's correct.
Very good. That's an important point to make.
Very important.
BPH is a term you'll hear relating to the prostate. So what is BPH?
So BPH is benign prostatic hyperplasia, and we'll refer to it to BPH for short, but it's basically an enlargement of the prostate, and it occurs in an area called the transitional zone of the prostate. It usually occurs in men around the age of 60, but that's not to say men younger experience the effects of BPH. Where the area that we're talking about is where the urethra leads the urine to exit the bladder. During urination, that area, there's a part right where it meets the prostate. And as the prostate enlarges, it can put some pressure on that urethra, leading men to have bothersome urinary symptoms.
So do we know exactly what causes BPH?
They don't really know exactly why some patients experience BPH symptoms and why they don't. They have a few posited theories, sometimes inflammation, or they think hypoxia, so not enough oxygen flow to that area. They think genetics may also have a component to it, and you'll meet some patients out there who they know that they are going to run into BPH issues in their lifetime, and they link up with a urologist earlier because of their dad, brother, or grandfather have kind of warned them about it and suggest that they link up with a urologist.
You mentioned that most people don't think about the prostate or talk about it until there's a problem.
That's right.
But it seems to me that most males now are aware of the prostate because we're hearing about more and more cases of prostate problems, and in particular prostate cancer. Do you think, or what does the research show about the number of prostate cancer cases? Is it just that we're more focused and more aware now, or do you think prostate cancer itself is a bigger issue?
I think that now there's more and more information and there's more research, and I would say that prostate cancer has undergone a little bit of a revolution in terms of the research and what can be done for it. The awareness is a little bit more increased now because I think patients and physicians are speaking more about it, whereas I think beforehand it was a little bit more taboo, kind of the way no one used to speak about breast cancer, and now you see a lot of NFL players wearing pink during certain months in order to increase that awareness. So I think prostate cancer is getting there, but not quite at the level of awareness as we would like.
So I went to see my primary physician a couple of months ago, checked the prostate, everything was fine, and that was my primary care physician, Dr. Dykman, as a matter of fact, at Ochsner. How does a patient know when it's time to see a urologist?
So again, most patients feel, when they see their primary care physician, sometimes if it's on their mind, they'll bring it up. I mean, I've been having issues with voiding, having any bothersome symptoms. And the classic symptoms of BPH are encompassed on a survey that I give to my patients who come in and see me for BPH. So it may be straining, weak stream, intermittency, meaning the flow starts and stops, or it may be symptoms of urgency or frequency of urination. So sometimes bothersome symptoms that a primary care physician will hear about, they may refer you to a urologist. Other times, like we were talking about before, some families just know they have enlarged prostates, and so they already kind of know they're going to come in and see a patient. So I would say if something on your mind about urination, or if you think, is this really normal, or if anything's really bothering you about the way you urinate, it may be good to at least get an evaluation with a urologist.
You did mention frequency, but I want to delve a little deeper into that. Having to get up to go to the restroom several times a night. I think I even heard one case, someone getting up a dozen times. What is normal? What is a normal amount of times to have to get up in the middle of the night to use the restroom? And does how much you drink before you go to bed have something to do with that?
It's hard to quantify nocturia, which is the way you describe waking up at night specifically to pee, as a normal or not a normal amount. I think mostly that one would tie into bother, and it's mostly a relationship to how much you're putting in your body with fluid hydration. So like you were saying before, if you drink water or coffee right up until you're going to sleep, then I would expect for a patient to wake up.
Let's talk about the prostate exam itself. What does the prostate exam entail?
So the full exam, of course, starts with what's called a history and a physical. So in the beginning, we'll discuss how bothersome the urinary symptoms are that we were talking about. Often I give my patients an impartial survey that they'll fill out before we speak to each other, just to get an objective view of how they're urinating. And the actual physical exam component involves a genital urinary exam as well as a digital rectal exam to examine the prostate.
Okay. Now, I asked you for permission for this before we started the program of this evening, but talk to me about you being a female, the patients being male. One of the things you described is a digital rectal exam. How uncomfortable is that for you as the physician? And perhaps more importantly, how uncomfortable is that for the patients? And when I first brought it up to you, you said, I'm glad you're asking that question because it is something that we have to discuss.
Absolutely. I think a physical exam, as far as a patient meeting a urologist for the first time, especially for prostatic evaluation, is something that's extremely important. It can give us very much information about it, and it may be life-saving in some cases. As we were talking about, sometimes other things come up, such as prostate cancer and other things that we're looking into during a BPH evaluation. I don't find it awkward at all. It's part of my job. It is absolutely something I conduct with absolute professionalism.
You says in residency, though, you quickly knew it was going to be an issue for some people, right?
I did. So I find that it's important to at least breach the topic, talk about it, and put patients at ease, because I think oftentimes they think it's a little bit more entailed and just an awkward situation. But honestly, it's something that's part of my job, is very routine for me. So most of the time, it's just something, once we talk about it, everyone feels more comfortable.
And what are you feeling for in the digital rectal exam?
So the rectal exam is not the most ideal way to examine the prostate, but it gives us a rough idea about if the prostate's enlarged, how symmetrical the gland is, and in cases where we're worried about prostate cancer, we feel for any hard areas that might be concerning, a concerning nodule, where we would think about prostate cancer as a differential.
And that's just a first step, obviously. That's not the gold standard, but pointing you in the right direction of potential problems.
That's right.
So what else, what other tests or tests may be involved in a routine exam?
Most of the time, we'll ask the patient to give us a urine specimen, which we'll dip for a urinalysis, and that's to ensure that there's no urinary tract infection or blood in the urine. If there is, that might also lead us to do additional workup in addition to the original reason why a patient came and see me. Bladder scan is an optional thing where sometimes I'll have the patient, after they give us a urine sample, we'll use an ultrasound machine. And this ultrasound is not invasive, it just goes over the lower suprapubic area and it gives us a rough idea of how much is left in the bladder after a patient voids. And there's also a machine called a Uroflow, which we have a patient void into, and it gets an idea of their flow and just kind of an objective idea to see how they're voiding and see how their stream is doing. And we'll also often review that too.
Based on what you find, are there any other tests you could order?
There are more tests, and this doesn't necessarily apply to everybody, but just briefly, there is something called a cystoscopy, where we insert a camera in through the urethra into the bladder, and we'll also evaluate the prostate during that time. There is also a transrectal ultrasound, which can be used to get an idea of a prostate volume or how large the prostate is to get us an actual quantifiable number. And there's something called urodynamics, which is a test that I don't really order routinely unless there's a question of, is there something else going on other than BPH here?
If BPH is causing urinary symptoms, where do you start, and are there other options? I guess with medication first, is that an option?
Medication is an option, but some patients out there, they do have a lot of medicines that they're already taking, blood pressure medicines, blood thinners, and things like that. So first, I actually try and talk to them about behavioral things, what you were alluding to before, just seeing how much they are hydrating, how much they're hydrating closer to bedtime to address, for example, nocturia, which is waking up at night to pee, and maybe decreasing fluid in the evenings. That also helps cutting down on waking up at night, which is very distressful and bothersome to a patient. Other things would be considering if patients are on diuretics, which are fluid pills. Some patients have done very well with switching the fluid pill timing to the morning, so they're not waking up at night if they take it closer to the evening. There's something called pseudoephedrine, which is a decongestant, and there's also diet supplements that contain ephedra. And for some reason, they have been linked to what's called a flare-up, meaning leading to some more bothersome urinary symptoms. So I counsel patients to avoid that. There's also things that are what's called bladder irritants that may just aggravate the bladder, such as coffee, tea, which anything that contains caffeine. Smoking is also another offender that bothers the bladder, so those may be leading to some of the urinary symptoms too. So the advantages of starting these behavioral things is you actually don't lose very much by it. You don't have to take an additional medicine, and often you can find that it may be very helpful.
If medication is the route, in which direction, what are the options there?
So there's an alpha blocker, and there's different types of it, but the idea is that it helps relax the area called the bladder neck. And that's the area where the urine leaves the bladder and encounters the prostate. So that area helps that bladder neck relax in order to empty a little bit more effectively. Most patients report an improvement in their stream. Sometimes the straining improves, and also the intermittency where the urine flow starts and stops. There's also a medicine called finasteride, or you also see Avodart out there, or dutasteride, and these are 5-alpha reductase inhibitors. These don't work as fast as the first medicine I was talking about, the alpha blockers, but they do work over time to slowly shrink the prostate. We do reserve them in patients who do have a larger prostate volume, because that's the patient group that they've been shown to help the most.
Okay. What if a patient doesn't respond to a particular medication?
So I would usually counsel my patients to start a medicine. For example, if we started an alpha blocker called Flomax, I would counsel them to stick with it for a month. Then, if it's really not helping and they're still bothered and not quite all the way satisfied, I'll have them come back to the clinic. Let's reassess and see what bothersome symptoms there are. My own practice, I try not to start too many medicines at once. So if a patient, for example, has an enlarged gland, when I did my exam and I've started them on Flomax, they come back a month and a half later, they're not quite happy, we can also do something called dual therapy in certain patients where they're on 2 of those medicines that we just talked about, the alpha blocker and the 5-alpha reductase inhibitor. sometimes working in tandem, those medicines may have a patient improve on their symptoms to a good extent.
And based on what Dr. Wang's told us already, just an idea, if you're going to see her or any other urologist, probably a good idea to have a list of all the medications you're taking that have nothing to do with this, because that's something you're always going to look at.
Absolutely. I look at the medicines beforehand, and that's a good rule of thumb for any clinic visit, for not even just a specialist, but every clinic visit.
What about treating urgency and frequency?
So those are typically perceived as overactive bladder symptoms. So to me, I try and categorize them a little bit differently from the obstructive symptoms that may be related to BPH. Those are usually treated with overactive bladder medicines, and there are often commercials about it on TV where you feel like you got to go and you can't postpone it. So there's a whole slew of overactive bladder medicines that I usually offer to a patient for urgency and frequency symptoms.
Okay. What about the whole idea of drugs being advertised on television? Ask your doctor, because I'm told to ask my doctor about, a laundry list of things. Does that ever make you uncomfortable? And what do you think about that whole concept of direct patient advertising or speaking directly to the patients from the drug companies?
I think that's something that's out there, and for me, I try to embrace as much as possible and get that information out there. If it happens to spark an idea that a physician and their patient hadn't had before, I think it can be helpful. It can be tough if it's not really an indicated medicine for that patient, but I think only more counseling and research and a discussion can be helpful. So more knowledge is power.
So you're happy to tell a patient, yes, this may make sense for you, or sorry, wrong idea.
Yes.
All right. Our guest is Dr. Julie Wang, and tonight we're talking about the prostate and benign prostatic hyperplasia, or BPH. At what point does surgery become an option for patients?
So the first indication to consider surgery is if a patient has tried the medicine, given it that time, and it really has not improved their symptoms to the point where they're satisfied. Or there are patients out there who are unable to tolerate the medicine because they do have some side effects. Before we start the medicines, I usually go over all the side effect profiles, in which case, if at that point they're unable to tolerate it, we might consider doing surgery.
What might some of those complications be? Not just specific medications, but...
Some of the medicines may make patients feel lightheaded. It's usually more encountered in patients who are already on antihypertensive or blood pressure medications, or patients who are elderly. So before starting these medications, I already usually give my patients a little bit of a warning to tell them these are the things to look out for. And if they truly can't take these medicines, then I would say the surgery is probably going to be, we're probably going to consider it a little bit more earlier than a patient who is tolerating the medicines and giving it the full trial and seeing if that helps them.
All right. Let's talk about the surgical options for BPH.
So the surgical options all involve some way in order to remove those bothersome blocked tissue that's leading to the patient's bothersome urinary symptoms. So the traditional way to do it is something called a transurethral resection of the prostate. It's where we introduce a camera into the urethra, find where those blocked tissue are, and use a tool in order to scrape that prostatic tissue a little bit more open to open up the urethra. There's a little bit of a different way to do it, also transurethral, meaning no incisions, where we use a laser in order to ablate or vaporize that blocking tissue. And there's also something called a UroLift, which is a little bit more new, and it's a technology that involves a quite minimally invasive way, where it involves a suture and two tacking barbs at the end of it, and one barb goes through the prostate towards the capsule, and the other part is a stainless steel part where it kind of compresses that tissue to help remove that blocked tissue.
Just the word barb scared me to death. Please tell me I'm asleep, or at least have no idea what's going on.
Yeah, so these procedures are conducted under anesthesia, and barb maybe have been a little bit of a strong word, but it's basically a tool where it goes through the prostate and then helps anchor it on both sides. So anchoring, I think, would be a better word to describe it.
Very good. Let's talk about the benefits of, you described several surgeries, so let's talk about the benefits of each of them.
So I'll go through the TURP, or the traditional transurethral resection of the prostate, where we're scraping the prostatic urethra open in order to help remove that blocked tissue. So the benefit is it's a minimally invasive surgery. No incisions are involved with the surgery. And again, it does help very much so with those blocked urinary symptoms such as straining, weak stream, and intermittency. Most of the time, patients can go home on the same day. And what we also do is sometimes if we're worried about other things, we can also obtain specimens, because as we scrape the prostate open, we'll have some tissue that we can send off to pathology. The vaporization is also something that's a same-day surgery, no new cuts or incision like that at all. And in this one, the tissue is slowly vaporized with a laser. It's a little bit better in terms of bleeding risk. It's a little bit lower risk than the traditional TURP procedure. And most patients, again, are able to go home on the same day. The tougher thing is that in patients with larger glands, it may require a little bit of a longer surgery, whereas the scraping, it may move along a little quicker. And laser vaporization also is something I consider more so in patients who may be on blood thinners and have to restart them fairly quickly after surgery.
So many times a patient's symptoms or patient's size is going to help determine which surgery is best.
Exactly. That's exactly right.
Okay. If a patient chooses the UroLift procedure, I know there's some extra steps that may need to take place on the front end of things.
That's right. So in order to evaluate a patient for a UroLift procedure, you have to have something called a prostatic volume measurement. So that will involve a rectal exam and a transrectal ultrasound, which is done in the clinic in order to measure the size of the prostate. These things are part of the indications for the UroLift, and if you have a prostate gland volume that's greater than 80 grams, then they typically do not recommend the UroLift procedure for that. And the cystoscopy is used to evaluate the prostate enlargement and see, just the blocked tissue in person, so that way you can counsel the patient about how likely you think the UroLift will be able to help them.
All right. We talked about the possible side effects with medications, always on this program, and transparency and fairness. We talk about the risks associated with surgeries, and there always are some risks. So let's talk about these risks in particular.
So excluding the anesthesia risk, which again, whenever patients go in through anesthesia, they'll meet with the anesthesiologist, and often we'll have them meet with their primary care doctor or a cardiologist if needed preoperatively. But there are risks of discomfort afterwards or pain, which I always give my patients some help with pain medicines to go home with. There's also a possibility of infection, in which case we always check the urine specimen beforehand to make sure there's no infection. I would counsel the patient to expect bleeding, meaning pink urine, after the surgery. Oftentimes, after the TURP, the traditional resection, or even a laser vaporization, you do go home with something called a Foley catheter. So it's a tube that drains the urine from the bladder to a leg bag that patients go home with temporary basis. For a UroLift, the risk of bleeding is much less than a TURP or even the laser vaporization, which is already less than the traditional TURP. And the UroLift, actually, some patients can go home without a Foley catheter, so that's actually a very beneficial thing for patients.
All right, we have just about a minute and a half left, so let's talk about recovery after surgery, the timing of that, and also just because the surgery is successful doesn't mean always that all the symptoms have gone away, correct?
Absolutely. So like we were talking about, most patients do go home the same day. A catheter is left in somewhere on the order of 3 to 5 days and removed here in the clinic when they come back and see me. When they go home, patients can get up, walk around, go up steps, get in and out of cars, but I recommend no driving, at least while the catheter is in place, and no heavy lifting for about 2 weeks, just to allow for maximal healing. And also, in order for the patient to get evaluation for surgery, we always talk about the possibility that sometimes, even though we remove that blocking tissue that's leading to their symptoms, it may not help them. In about 15 to 20% of patients, they still do have persistent or some degree of bothersome voiding symptoms afterwards.
All right. Dr. Wang, thank you so much. Again, thank you for returning to your hometown, being here with your family, and more importantly, being with us. Thank you so much.
Thank you very much.
Thank you.
Thanks.
Dr. Julie Wang. Well, I want to thank Dr. Wang for the education and information she's provided tonight and for her work in the Ochsner Health System. To make an appointment with any of Ochsner's physicians, including tonight's guest, Dr. Julie Wang, or to register for any of Ochsner's Hello Health seminars, they take place almost every week across the greater New Orleans area. You can call Ochsner at this number, set up just for viewers of this program. And you can also send us questions by email, hellohealth@ochsner.org. As a reminder, you can rewatch tonight's presentation or any of our Hello Health programs on Ochsner's website at ochsner.org. Just type Hello Health in the search areas and that'll get you started. Our thanks again to tonight's guest. Thanks to Humana and Ochsner for making our program possible. And our final thanks, as always, is to you for your support of this program, Hello Health. We'll see you next time.